can go for intervention, ultrasound guided or other intervention to help in the management of the patient. So first I'll be showing you a case, and then we'll be seeing the video of the case. Okay. I'm sharing the screen. Can we see the screen, sir?
Yes, we can.
Okay. So this is a lady who came to my clinic a month back with main pain in the knee pain. For she had a knee pain for 4 years. She had a hand pain for 2 months, and she also had a shoulder pain for 8 months. And when examining, she was a known case of osteoarthritis knee, and she also because of the osteoarthritis knee, she was having a knee pain for last 4 months, 4 years. She was having a thumb pain, and on examination it was found to be a trigger finger. She had a history of cervical disc prolapse for which she had a surgery in 2016. And initially she was diagnosed as frozen shoulder by the orthopedic doctors, and she came to my clinic for the management of frozen shoulder, thinking that the problem was frozen shoulder. But on a detailed examination of the patient, the frozen shoulder was not the case. And unfortunately, after the examination, we had to refer the case to the neurologist for further management. So this is one of the very interesting case in which we sometimes have, if there is any red flag, we have to refer the patient for multidisciplinary management. And you'll be seeing the examination of the patient in which we had to refer, and why we are referring to the patient also will be seeing in this video. Okay. So I'll be presenting you the main video of the patient. 1 minute. Okay. So so I'm showing you a shoulder examination of a lady, 54-year-old lady, who came to my.
Series, you stop sharing this first and then you share the other one.
Yes, sir. I'm stop sharing this first. Okay.
And now you share the video.
Today, and so is the video visible, sir?
Yes, visible.
Okay, and the sound is also visible.
Yes, yes.
Okay. So I'm showing you a shoulder examination of a lady, 54-year-old lady, who came to my clinic today. And initially she was diagnosed with frozen shoulder, but after the examination, we found out that frozen shoulder was not there. Okay. So the first step of examining one shoulder is to check the range of motion. So I'm checking the active range of motion. So okay. Now you can see Now you can see the active range of motion of this is not there. Now I'm checking the range of motion passively. So now you can see passively the hand can be moved up. So here the active range of motion is impaired, but passive range of motion is normal. So this basically means there is a problem in rotator cuff injury. Or after checking range of motion, the next step is to check the strength of the muscle. So to check the strength of the muscle, we have three tests. Abduct the hand 90 degree, slightly do adduction, and empty the can like this. After doing this, I'll apply pressure over the forearm. Okay. So can you see the strength of this muscle is less? So this means the supraspinatus muscle is weak in this patient. Another test is belly press test. So what you do is do like this. Ask the patient to press the belly and one of the thisnos time. So can you see she cannot maintain the internal rotation. Her your elbow is coming back. So this is the belly test positive. Test is also positive. So that means the problem is with the subscapularis also. The final muscle test is the infraspinal test and teres minor. So what we do is arm in neutral position, elbow flex at 90 degrees and tell the patient to externally rotate. So okay, as I apply resistance over here, am I can you see this hand moves, but this she cannot do this. So all three muscle test is positive in this patient. So another test we can do is to take the to check the rotator cuff. So here I am checking the rotator cuff of this patient. The first test is the drop arm test. So basically do abduct the hand like this and tell the patient to hold. So I'm passively moving her hand like this, abducting the hand. So I'm telling the patient to hold the hand like this. So you'll notice the hand which she cannot hold will drop down. Okay. So I'm leaving the hand. Can you see the hand just moves and she tends to go towards the body tends to lean towards the hand which is weak. So I'm testing this again. So this is a drop arm test, usually done to check the supraspinatus and infraspinatus integrity. Here I'm passively abducting the hand. Now I will leave this hand will go down. Okay. Slowly beside tall lanu's so this hand will move fast. So drop arm test is positive. Another test, what I can do is extension lag test. So this is the hand abduction 30 degree, 90 degree elbow bend, and I will do maximum external rotation. Now, when I leave this, our hand, if there is problem, our hand will come like this. Okay, I'm checking like this. Now, can you see? This is extension lag test positive. So this is the extension lag positive test positive. Thank you. So in this video, you have just seen when the patient comes.
Series, I'll be requesting you one thing. Before explaining and going into this patient is having basically multiple pathologies. So instead of showing the 3 different cases, here only we will be discussing all because this patient already have the 3-4 different pathologies. But before that series, I'll be asking you to quickly go about the steps of the physical examinations, like the starting from the inspection, palpation, range of movement, neurological examination, special test. Just quickly just go through that, and then you come to this point and this patient, and we'll be discussing this patient again.
Okay.
Because for the recapitulation, many might be new, many might not be knowing exactly the steps how to examine. So you just quickly go through it, and then you come back to this patient.
Shall I share the slide, sir? It will be easier.
Yes. You can show the slide. You can show the slide.
So I'll be, I have one slide which basically detailsly tell you what are the steps that you have to see when the patient comes to clinic.
Right. When the patient comes to the shoulder pain, so what are the, how to, examine the patient, quickly the steps, and then we'll be coming to this particular patient.
Okay, sir. Is my slide visible, sir? Hello, is my slide visible, sir?
Yes, it is visible.
So normally when any patient comes, not only with clinical pain in the shoulder, but any pain, we basically follow this algorithm. We try to put what are the various causes that can cause the pathology. Second, we try to find a red flag, then history, followed by clinical examination, investigation, and diagnosis. This is the normal algorithm that we follow while any patient comes to the pain clinic. For the shoulder pain, there can be multiple pain cause of shoulder pain. It can be secondary to trauma. It can be non-traumatic. And in case of traumatic causes of shoulder pain, it can be secondary to fracture of the shoulder joint, mainly the bones that forms the shoulder joint, that is humerus, clavicle, scapula, or it can be due to the dislocation of the shoulder joint. As we know, the shoulder joint is basically a ball and socket type of joint in which the socket is very small and the head of the humerus is very big. So because of this configuration, the shoulder joint tend to dislocate much more commonly than any other joint. So a third traumatic cause can be a ligamental sprain. And other causes of shoulder joint is basically a non-traumatic cause, which is more common, and we are more focusing in the non-traumatic causes of shoulder joint. And non-traumatic causes of shoulder joint can also be intrinsic cause as well as extrinsic cause. Intrinsic cause basically means the problem is inside the shoulder joint complex itself, and extrinsic cause means the problem is outside the shoulder joint. That is normally a referred pain. Pathology is not in the shoulder joint but away from the shoulder joint, but patient is coming with the pain in the shoulder joint. So in intrinsic cause, that is inside the shoulder joint complex, pathology can be glenohumeral, that is main shoulder joint, or extra glenohumeral, that is slightly outside the shoulder joint, but it is within the shoulder joint complex itself. So most common cause of glenohumeral cause is the osteoarthritis of the shoulder joint, which is followed by instability of shoulder joint. It can be secondary to the labral tear, or it can be secondary to adhesive capsulitis. We commonly cause the name this as a frozen shoulder, or it can be secondary to rotator cuff tear or tendinopathy. The case which we have just seen is basically a rotator cuff tear or tendinopathy. Secondary, it can also be due to subscapular or subacromial bursitis, or the intrinsic cause can be extra glenohumeral, such as outside the main shoulder joint, that is acromial clavicular joint osteoarthritis. It can be secondary to the bicipital tendinopathy, or it can be subscapular bursitis. Okay, so these are the intrinsic cause of the shoulder joint, causes of shoulder pain. And coming to extrinsic cause, that means problem is not within the shoulder joint but outside the shoulder joint, such as like cervical disc herniation, mainly involving C5 and C6. It can be due to the cervical spinal canal stenosis or lateral canal stenosis. It can be due to the post-herpetic neuralgia involving mainly C5 and C6, or it can be due to the chronic regional pain syndrome of upper arm and shoulder, or it can be referred pain mainly by like diaphragmatic irritation can also cause shoulder pain, or myocardial infarction can also cause shoulder pain, or any intrathoracic tumor can also cause shoulder pain, or any muscle spasm, mainly the spasm of the trapezius can cause a shoulder joint. So normally, as you can see, there are multiple pain generators in the shoulder joint, but most common cause is the intrinsic cause of the shoulder pain. So among the intrinsic cause also, the most common is glenohumeral osteoarthritis as shown in this PowerPoint, or it can be rotator cuff tear or tendinopathy, or it can be secondary to the subacromial subdeltoid bursitis, or osteoarthritis of the shoulder joint, and frozen shoulder is also one of the most common cause. So when evaluating the patient with shoulder joint, we have to keep all the causes of the shoulder joint in our mind, and in the evaluation we always have to first try to find out red flags. So red flag basically means the patient is having shoulder joint pain, but it is usually not managed conservatively, and we have to send the patient for the multidisciplinary management. We may have to refer the patient to neurologist, or we may have to refer the patient to orthopedics because it is not in our domain for the management. So most of the causes of red flag is basically fracture of the bone that forms the shoulder joint, that is fracture of the clavicle, fracture of the humerus, or fracture of the scapula. This can be a red flag. Another is dislocation of the shoulder joint. So we are basically are not treating any dislocation. So this is mainly treated by orthopedician. So if there is any dislocation, we have to refer the patient to neurologist or orthopedician. If there is any tumor of the shoulder joint also, this is not in our domain. Another is septic arthritis of the shoulder joint is also the condition where we may have to refer to the orthopedician. Or if there is unexplained sensory or motor loss, so these are all causes of the red flag in which we have to refer to the respective department for the management. So normally when we when the patient comes with shoulder joint pain, we basically ask the history in detail and followed by physical examination. So history and physical examination alone can diagnose in 80% cases of the shoulder pain or any other pain. So most important is history and physical examination. So in history, we basically follow this chart in our Daradia, the pain clinic. This is the history sheet that we commonly follow in our clinic, which I have shown in the PowerPoint. And so in history basically starts with age of the patient. So there are certain diseases which are common in young ages. There are certain conditions which are common in old ages. For example, if patient comes with shoulder pain and the patient's age is very young, so in these conditions we might think that it can be a inflammatory arthropathy, like for example rheumatoid arthritis can be one of the cause, or gouty arthritis can be another cause. Or if the patient's age is old, so in old cases normally the shoulder pain is usually osteoarthritis of the shoulder joint. Okay, and if the patient is young but he has a history of like he is involved in physical activity, sports activity, then in those cases the cause of shoulder joint pain can be a tear in the shoulder rotator cuff or tendinopathy in the rotator cuff because of multiple use of the shoulder joint or prolonged use of the shoulder joint. Second, in history, we also have to ask occupational history is also important. So in case of occupational history, some conditions are common in case of in certain occupations. For example, if the patient is like professional athletic, and in these professional athletics, especially there can be rotator cuff tear and tendinopathy are very much common in these conditions. And another is like duration of pain. History of pain is also very much important. So how the pain started, was it gradual, or was the pain spontaneous and sudden, or if the pain is usually accompanied by any trauma or fall or any injury. So that history is also important, which can give us clue whether what may be the underlying pathology. And second, in pain history, we always have to ask history about like what is the intensity of the pain, whether the pain is mild, whether the pain is moderate, or whether the pain is severe. And we also have to qualitative assessment of pain is also important. In qualitative assessment of pain, we basically ask the history and to find out whether it is a neuropathic in nature. That means whether the pain is originating from the muscle or joint, or it may be a neuropathic in nature. That means nerve impingement, especially the cervical disc prolapse or long thoracic nerve or suprascapular nerve impingement can also cause shoulder pain. So these are the few things that we have to ask in history to find out the cause. And after in the history, after finding out, we have to do physical examination. So physical examination is also very much necessary. With physical examination alone we can diagnose, without any investigation also we can diagnose, come to the diagnosis in 80% of the cases. So in physical examination we basically go for inspection of the patient, followed by palpation and we check the range of motion, we check the muscle strength, as well as there are few special tests which we commonly do when there is a patient with shoulder joint pain. And when examining the shoulder joint or any joint, we usually have to examine the joint which is proximal to the pathology as well as distal to the pathology. And since God has given us two shoulder, we always have to compare with the other shoulder while doing inspection, palpation, or any other physical test. It's better to compare with the other shoulder joint, or the shoulder joint which the pain, where the pain is not where the patient is not complaining of pain. So in inspection we usually start with informal observation of the patient. That means inspection is usually starts as soon as the patient enters into our clinic. So this is basically an informal observation. We observe the patient, how the patient is coming to our clinic, how the patient is holding his hand, what is the facial expression of the patient, is the patient the dominant hand, whether there is any support to the painful shoulder or not. Yeah, so these are the informal observation that usually we see for in case of inspection. And after the informal observation, we usually go for formal inspection. Formal inspection means basically inspecting the shoulder from front side, from the sidewise, also from the back. And in formal inspection, we basically see for any swelling in the shoulder joint, any deformity in the shoulder joint, or if there is any muscle atrophy or muscle weakness around the shoulder joint, or if there is any scar mark or any ecchymosis or any venous distension. So these are the few things that we see in the shoulder joint from front, side, as well as from the back. And we always have to compare with the other shoulder that the patient is not complaining of pain. So in inspection, there are informal observation, which starts as soon as the patient comes to the clinic till we finish our physical examination. And another is formal inspection, where we usually see deformity, swelling, or any like scar mark, any signs of injury or venous distension or muscle atrophy. So after inspection, second is palpation. Palpation is also equally important. Here we palpate all the joint which forms the shoulder joint. So shoulder joint complex basically starts with sternoclavicular joint. It also consists of acromioclavicle joint. It also consists of main shoulder joint proper, that is glenohumeral joint. And there is another joint that is floating joint, so that posterior aspect of the scapula. So all four joints has to be palpated. And apart from joint, we also palpate all the bone that forms the shoulder joint. Suppose, for example, we have to palpate the clavicle, we have to palpate the humerus, we have to palpate the scapula. So these are the main three bone that forms the shoulder joint. So palpation of all the joint has to be done. And we also have to palpate the mainly the muscle that helps in the to stabilize the shoulder joint. That is basically the trapezius. We palpate the suprascapular muscle, we palpate the infrascapular muscle, we can also palpate the deltoid as well as subscapularis. These muscle palpation of this muscle is also important in clinical examination of the patient. After palpation of the patient's structure that forms the shoulder joint, another is to check the range of motion. So we have already seen in the video how to check the range of motion. Here all the range of motion has to be checked. For example, forward flexion of the shoulder joint, extension of the shoulder joint, adduction of the shoulder joint, abduction of the shoulder joint, as well as internal rotation of the shoulder joint, external rotation of the shoulder joint, as well as hyperabduction of the shoulder joint. So this range of motion has to be checked. And this range of motion has to be checked in both active range of motion has to be checked. Another is passive range of motion has to be checked. Active range of motion basically means patient has to do all the range of motion by himself. And in passive range of motion, we help to do all the range of motion that I've already listed. That is flexion, extension, abduction, adduction, everything. So we also have to, and if the range of motion is painful, then we can put the patient in supine position. What happens in supine position? The muscle which basically grips the shoulder joint will becomes relaxed, and patient might be able to do the range of motion without pain or with less pain. So range of motion is the first thing that has to be checked in the patient with any shoulder joint pathology. So after the range of motion, normally we check the Apley scratch test is the common test which we do to check the range of motion. Here we basically ask the patient to touch the opposite side of the scapular blade from upwards and from also from the lower side. So here we are checking basically the external rotation and adduction in the left side of the picture, and in the right side of the picture of the PowerPoint we are checking basically adduction and internal rotation. So by the simple Apley scratch test we can find out whether there is problem in abduction or external rotation or adduction and internal rotation. So this is the common test which we commonly do in checking the range of motion. After the range of motion, we check the muscle strength. So muscle strength basically is for checking any rotator cuff pathology. So rotator cuff pathology can be due to rotator cuff tendinopathy, or it can be due to the rotator cuff tear. So in both rotator cuff tendinopathy and rotator cuff tear, muscle strength can be decreased. So to find out whether is whether the muscle strength is true due to the weakness of the rotator cuff, or it can be false, because in case of pain also, patient tend to have a decreased strength in the muscle strength. So in this test, we can simply inject a local anesthetic solution in subarachnoid bursa and again check. So after the injection in the subarachnoid acromion subdeltoid bursa, if the muscle strength improve, then it is a false muscle weakness. If the muscle weakness persists even after injection of local anesthetic in subacromial subdeltoid bursa, it is a true muscle weakness. And for this, we basically go for three tests. One is empty can test, another is belly test, and third one is test for infraspinal test and teres minor. So this is the test which we do for to check the muscle strength of supraspinatus muscle. So in this test, patient's position is either sitting or standing, and we ask the patient to do 90-degree abduction and 30-degree adduction, and then fully internally rotate the hand like we are emptying the can. Suppose if this is a can, we ask the patient to do the internal rotation so as to decrease the so as to empty the can. So this is another test which we commonly do. So and in while doing this, we basically stand behind and press the forearm from backside. So if there is any weakness, then they will have pain in the shoulder joint. Here we mainly focus on pain, weakness, and we basically do not focus on pain. So this is one empty can test is there. Another test we commonly do is so I'm showing you a shoulder exam. Sorry, so there's a lady, 54 years old. Sorry, this is the I don't know what's 1 minute. So I'm showing you a. So there is a water spell. Excuse me. I came to my clinic today, and initially she was diabetic. So, so there is some problem in the water spell.
Did you close the video? Then you continue this.
Okay, sir. There is a. So there is a some.
Okay, now you can make it a full screen and you can start.
Here the water spells us so that there is. Is the slide visible, sir?
Slide is visible. Make it full screen.
It is full screen. In my slide, it is full screen, sir.
No, we are unable to see the full screen. Okay, you are towards the end of the screen. You can go scroll down and you can go ahead with the last screen.
Sir,
You can stop sharing and you can share it again.
Okay, here
Please stop sharing, then again share, please.
Okay, so my computer is hanged, sir. Can you see the slide, sir?
Yes, now we can see.
Okay. So here it is all going haywire. Is it visible, sir, now?
Yes, full screen is visible. Go ahead.
So we are belly press test. So another test to do the muscle strength test is belly press test. In this test, basically it is for the test for basically it is a subscapulary test. Here the patient's position is either sitting or standing, and we ask the patient to press the belly with maximal internal rotation. So normally when we do this test, normally patient is able to do the maximal internal rotation without the elbow lagging behind. So if there is any weakness in the subscapularis, you will not be able to press the belly with full internal rotation. While doing this, the usually the elbow of the patient lags behind, as you just saw in the video. Third test is basically, sir, here third test is for the this external rotation lag sign. So this is also to test the uh, yeah, my computer is hang, sir. Sir, my computer is not working nicely.
You do one thing. You restart it. Meanwhile, you can continue the discussion. You restart your computer.
Yes, sir. Yes, sir.
Okay, so what has been discussed by Dr. Series that whenever you are examining a patient suffering from any kind of pain, may it be headache or it is shoulder pain, or we'll be going to the all different kinds of pain in the subsequent classes. But the basic steps we have to remember are all same. So first of all, what you have to do, we have to remember and we have to understand what are the causes. Like here in the shoulder pain, we have to understand what are the causes of shoulder pain. And then what we have to understand, what are the red flags, what are the dangerous signs. And then we should start taking the history and then examinations, then your different investigations, and then your final diagnosis and plan of management. So first you have to remember the causes, and in the causes what was important, that the whole shoulder pain can be divided, not only shoulder, the same things applicable for the others as well. One is intrinsic, other is extrinsic. Intrinsic means that what are the causes of the shoulder joint, and again shoulder joint is not one joint, it is a complex joint. It has the four joints, the glenohumeral, acromioclavicular, then your sternoclavicular, and your scapulothoracic. So scapulothoracic is a false joint, but any of these joint pain can cause the intrinsic, that is the cause of the intrinsic shoulder joint pain. And extrinsic means which will be referred from other structures, not for the shoulder joint structures. So like if there is something has in the cervical radicular pain involving the C5 or C4, so the patient might be presented with the shoulder joint pain. Patient might be having the facet joint pain, which is referred to the shoulder joint. Patient might be having the myofascial pain involving any of the rotator cuff muscles or muscles around the covering the shoulder joint like deltoid. So this myofascial pain of these muscles can also a cause of the shoulder pain. Trapezius also, part of the shoulder joint is covered by the trapezius also. So any of the myofascial pain of this outside the shoulder joint is basically a referred pain. And the other referred pain can be from the either abdomen, diaphragm, or the chest, which can be referred into the shoulder. So these are the different extrinsic causes and intrinsic causes. So this joint and the different ligaments, muscles, bursas in the shoulder joint are the intrinsic causes. Now, for the sake of our understanding, we normally divide conventionally in the all intrinsic causes into glenohumeral cause and extraglenohumeral cause. So what are there in the glenohumeral cause? So here there are some debates. Some book says that glenohumeral is only the main glenohumeral joint, which do not include the rotator cuff. But some books mention that rotator cuff is also a part of the glenohumeral joint. Here, the series has mentioned that the rotator cuff are also the part of the glenohumeral joint. But some textbook says that the glenohumeral joint is not the cause, is not the rotator cuff. There, they mention only the shoulder joint causes. So glenohumeral joint causes. So glenohumeral joint causes are most common is your adhesive capsulitis, and second most common for the glenohumeral joint pain is your osteoarthritis of the glenohumeral joint. Osteoarthritis of the glenohumeral joint is less common compared to that of the knee joint, hip joint. So osteoarthritis of the glenohumeral joint is not a very common cause. Comparatively, the rotator cuff and the frozen shoulders are more common cause. So now rotator cuff tendinopathies and tear, you may or may not include in the glenohumeral cause. So as I told you, some authority says that rotator cuff is extraglenohumeral. Some book says that it is within the glenohumeral joint. But anyway, rotator cuff tendons, we all know there are 4 rotator cuffs. The supraspinatus, which causes the abduction, the infraspinatus and teres minor, which causes the external rotation, and the subscapularis, which causes the internal rotation. So these 3 movements, abduction, internal rotation, external rotation, these are done by 4 rotator cuff muscles. So tendinopathies of this muscle or tear of this muscle is one of the very important causes of the shoulder pain. And there are bursas around all these tendons. So the most common bursa is your subacromial subdeltoid. That is basically around the supraspinatus. And there are bursa also around below or above the other tendons, rotator cuffs as well. Those are also the common causes of the shoulder pain. So all shoulder pains are not frozen shoulder. So you have to remember all those other causes. Now coming to the extraglenohumeral. Extraglenohumeral, two causes are very common. One is your acromioclavicular joint osteoarthritis or arthritis. Another is your bicipital biceps tendinopathy. We know that the long head of the biceps is intracapsular. Within the joint capsule of the shoulder joint, glenohumeral joint, the bicipital tendons runs and goes and insert at the labrum and the superior part of the labrum. So it is intracapsular, and the pathology in the biceps tendon is one of the, again, common cause of the shoulder pain. So now if you are taking all this together and if you are listing what are the common causes of the shoulder pain, one of them is frozen shoulder or adhesive capsulitis. That is a glenohumeral joint cause. Next common is your rotator cuff. Rotator cuff again is 4. Out of this, most common is your supraspinatus, then your subscapularis and infraspinatus. So these are the 4 other causes. Then bursa, subdeltoid, subacromial bursa, then your subcoracoid bursa. These are the 2 common bursitis which can cause the shoulder pain. There are a few others, but these 2 are common. Then comes is your acromioclavicular joint and bicipital. So these are the different causes of shoulder pain. Now coming to the red flag. What are the conditions which you should be keeping in mind, which should be drawing our immediate attentions? So what are these red flags? One is if it is a traumatic shoulder pain, if it is associated with a fracture or dislocation, that is one of the red flag. If there is a tendon tear, if you are suspecting, that is a red flag. If you are amongst the extraglenohumeral joint, if there is a radiculopathy involving the motor weakness, then it is a red flag. And if there is a septic arthritis, it's a red flag. So these are the different malignancy. If you're suspecting, it can be the metastatic lesions also. The metastasis in the humeral head is not uncommon. And these are the different causes. Some of them are red flag. Now, if you're giving this, we have to go with the history. We have to understand that in the history, we should be starting from the pain when you are taking history. Then what is the intensity of the pain? What is the quality of the pain? What is the diurnal variation? Whether the pain is referred, whether the pain is localized. So this kind of all the kind of history of present illness to be taken after you are taking the chief complaint. And then the family history, the occupational history. So this kind of history should be taken. And then we should start the examinations part. In the examinations, we should start with your inspection, then palpation, then your range of movement, then is your special test, and then we should be thinking of further investigation to evaluate. In the further investigations, one of the very important investigations you always do nowadays in our pain clinic is your examinations of the shoulder with an ultrasound. And in that ultrasound diagnosis, ultrasound evaluation, one of the very important part is your dynamic evaluation with ultrasound. So like rotator cuff tendinopathies, the tear, the bursitis, the other things which can be very nicely diagnosed with ultrasound. No need of doing any MRI. And impingement can always be better diagnosed than MRI. If we are having a dynamic examinations, if we are thinking of that there is impingement, so that can be seen with the movement and holding the probe, ultrasound probe, to understand the impingement. And if still you are having a doubt, and on the medical legal aspects, if you want to establish your diagnosis legally or officially, then you should have an MRI reports also, or you should have the ultrasound done by your radiologist colleague. One thing you remember, the pain physicians themselves cannot write a radiological report by themselves. So in your own patients, you can do the scanning, but for the legal purpose, normally, when we are thinking of doing interventions, we we ask the patients to go outside for MRI or even an ultrasound scanning from outside. And after that, you can plan the management. Again, management plan can be either conservative, or it can be interventional, or it can be your surgical management. So now, before coming to our today's case discussions, so I'll be asking Siris. Siris, your computer has started again? Oh, Siris has already logged out. Okay, because his computer has been hanged. Okay, till he is joining. So these are the steps. And in this patient, now let us come to the little bit of discussions on in these particular cases. So here, what we have seen, that one very common thing I must be telling you, always remember that the frozen shoulder is a common cause, but not the only cause of the shoulder pain. There are a lot of other causes of the shoulder pain. As I told you, the few 5-6 common causes of the shoulder pain, and we have to keep all those in our mind. In this patient, on the very important test, what series has been demonstrated at the beginning, that he was unable to perform the range of movement, because unable to lift, but actively, but passively it was possible. So now, if somebody is having the restricted range of movement on the active movements, but the passive movement is normal, then you should be ruling out the possibility of the glenohumeral joint causes. Glenohumeral joint causes means it cannot be adhesive capsulitis, it cannot be osteoarthritis of the shoulder joint, or other glenohumeral joint causes your slap lesions, tear of the labrum. So if these pathologies are there, the both active and passive movement will be restricted. So if the patient is having the full passive range of movement, but the active range of movement is restricted, then you have to think that the glenohumeral causes are not there. Most likely it is associated with the rotator cuff or the other pathologies. So in these situations, what we have done the other test, in that test we have seen that all the 3 tendons, means test of these 3 tendons, like belly press test normally we do for the, because abduction, internal rotation is done by the subscapularis. So belly press test is a test for the internal rotation. So that was positive. That means subscapularis lesion was there. Subscapularis either tendinopathy or tear was there. Then your external lag sign, that is positive for the, because external rotation. And if you are asking the patient to hold in that position in the external rotation, this is done by your infraspinatus and your teres minor. So if somebody having a lesion in the infraspinatus, then patient cannot hold his hand in an externally rotated position. So this is what is external lag sign. Patient is unable to hold the hand in externally rotated position. That is known as external lag sign. So his hand will be coming back by the unopposed other rotators. So here in this patient, external lag sign was positive, indicating that probably the patient is having the external rotators lesion. And another very important thing was empty can test was positive. Patient was unable to hold the hand in this position and it was dropping. So keeping in this mind, so all those 3 rotator cuff was involved in this particular patient. Okay, Siris, your computer is now working. You are muted.
Accidentally water spilled in the keyboard, so everything is haywire, sir.
So are you ready to continue the class?
Yes, sir. Yes, I'll try, sir. Let's see. It is working.
Okay. So I was just recapitulating what we have discussed till now. That means what are the common causes of the shoulder pain, and what are the steps of the evaluation. And then I was coming to your case today, what you was discussing. I was just recapitulating. So
Okay,
you can start from where you have actually ended. You can start from there.
yes, sir. I'll try whether it. I'll again reach. Is the slide visible, sir?
Yes, it's visible.
Actually, the mouse is not nicely working. So okay. Okay, I think I was. I'll just shoulder examination of a lady. Sir, I think my computer is not working nicely, sir, because of water spell in this.
Okay, series. You can without presentation also you can just discuss the case. I started the discussing the case what you have presented, so you can go ahead with the discussion of that case.
Okay. So in the picture in the case, normally what we do is we basically go for examination as sir as told. We go for check the muscle strength. In muscle strength, there are three tests that we do. First one is the empty can test. Another, this is mainly for supraspinatus. Another is empty can test, which is mainly for supraspinatus. A belly press test, which is for subscapularis, and another is extension of the test for for the infraspinatus and teres minor. So these are the few tests that we do. Another is like to check the muscle strength. Okay, so to check muscle strength, you basically go for examination. We found out computer is working. Frozen shoulder was not there. Okay, so the first step of examining.
Series, you can stop these outline of the examinations. We have discussed.
Yeah, I am. The computer is working on its own, sir. I am not doing anything.
Okay,
It just
you stop sharing.
it just goes by itself, sir.
You stop sharing. Let us discuss about the case what you have presented. So you just come to your diagnosis and you justify what is your diagnostic point, why you are discussing about that diagnosis. This is the most important part of today's class, that why you are coming to that diagnosis and what is your plan of management and why.
Okay, so in the case that you have seen, uh, first the range of motion. As you could see, the patient's active range of motion was also impaired, but passive range of motion was normal. So normally what happens in case of glenohumeral cause or in case of shoulder joint pathology, especially osteoarthritis shoulder and frozen shoulder, both active and passive range of motion will be restricted. But as you can see in this in the case, active range of motion was restricted, but passive range of motion was normal. So I could easily flex and extend her hand or abduct her hand beyond her shoulder joint. That means active range of motion is normal, but passive is restricted. Passive is normal, but active is restricted. So usually this happens when there is a problem in rotator cuff problem, or either in rotator cuff tendinitis or tendinopathy or rotator cuff tear. So second clue in this test was the muscle strength test. You could see all the muscle strength test was negative. So for example, the empty can test was also positive, where we could easily press the hand, which was problematic. Another is belly press test was also positive. That means the problem was in sub scapularis also. And another is extrinsic and infraspinatus and teres minor test was also positive. So that means all the muscle weakness was present in all the rotator cuff. Third test we did was a special test, that is to check the muscle integrity. That we basically did the drop arm test. In drop arm test, positive means there is a tear in the muscle. It can be a partial tear or it can be a complete tear. Only drop arm test was not positive here. The other test for a muscle test was such as extensor rotation lag test was also positive. That means his infraspinatus and teres minor was also problematic. So here, as you could see, there was a profound neurological problem in the patient. Patient could not, there was not only a single muscle involved, all the muscle of rotator cuff, that is supraspinatus, infraspinatus, subscapularis, all the muscle weakness was also there, as well as all the muscle tear test was also positive. So normally,
So,
when,
series. So
okay,
let us start discussions from this point. That
yes.
means after taking the history and after doing the clinical examinations up to this point, what we have found, what is their positive findings, that the patient, the rotator cuff test was positive. Rotator cuff test for all the rotator cuffs, means for the subscapularis, for the supraspinatus, for the infraspinatus and tenospinals, all are positive. So there are few possibilities. One possibility is that the patient is having the tear or tendinopathies, so that patient cannot perform this test. And second possibility is that these muscles are weak because of the nerve supplying these muscles are damaged, or some of the neuropathy or radiculopathy is there. So how you are going to proceed further from this point?
So normally, sir, here, since all the tests are positive, I found out that it is a red flag for us, because like there was no history of trauma, nothing was there. Suddenly, the patient was having weakness of the all the rotator cuff. She had a history of cervical disc prolapse, for which she underwent surgery in 2016. So because the test, all the test was positive regarding muscle tear as well as weakness, I thought it was a red flag, and I basically referred the patient to the neurologist for the further management of the patient, sir.
So that is true. But what happened after that? What was the reason for this weakness? Was it tear, or was it some neurological deficits which causes the weakness?
On ultrasound examination of the patient, all the muscle were normal. So I did the ultrasound of the patient, of all the suprascapular, subscapularis, and all the rotator cuff muscles. I did the ultrasound scanning. In
That means
ultrasound,
one of the tests which has been done by yourself was the ultrasound, which can be very helpful in this situation to differentiate whether it is a really neurological deficit or it can be your the your
muscle tear.
yeah. Another important things to distinguish here is that whether the patient was how much was pain or versus weakness, which is more profound. Is it the pain more profound or weakness which is more profound?
uh, the weakness and inability to move the shoulder was more profound in this patient rather than pain.
Yes, this is very important. This also you have to remember, one very important thing is that when the patient is, we are on the clinical test, we are seeing that the patient is having unable to do that. So now patient's movement, unable to do the movement, can be because of the both these two. One can be because of pain, patient cannot move. One can be because of the weakness, because patient cannot move. And that weakness can be because of the muscle tear, or it can be because of the neurological deficits. So how to differentiate between these three categories? One is patient is cannot move because of the pain. One is patient cannot move because of the partial tear. We have already ruled out the frozen shoulder or the restricted movements, but there are other possibilities. In these situations, if there is a complete tear, then normally the patients becomes not that much of pain, but most of weakness is the most important the clinical presentations. If there is motor nerves which are basically involved because of some of the any of this the lesions in the either disc or some other things, then also the patient should be having the more of the weakness rather than pain. And another important thing is that if the patient is having the partial tear, then and tendinopathy, presentation will be more than the weakness. So these are the things which can be in your on your clinical examinations. But further investigations, like few investigations to be done here. One you have already done, that was your ultrasound, and you have seen the muscles are intact, muscles are normal and healthy looking. So most likely the tear and tendinopathies has been ruled out. So what is left here is mostly the neurological deficits. So have you followed up the patient about what was the final diagnosis or the other test to be done was done by the neurologist?
No, sir. After referral to the neurologist, she just called me and said that they have asked for MRI of the neck, cervical spine, and whole spine screening has been ordered. And then later on, patient didn't came for follow up after she went to the follow up of neurologist. But she called me after the neurological examination, neurologist, and she told me that MRI of cervical C spine has been ordered, and she after doing MRI she will go to the neurologist. So that was the final talk with the patient, sir.
Okay, so fine. So you have to understand that what are the red flags, as I told already, complete tear, full thickness tear, the traumatic injury, the labral tear, dislocation, fracture. These are all red flags. Along with that, neurodeficit is also a red flag. So this was this patient, and I'll be asking the questions. As I told you, the most important part of this course is the discussion part. So I'll be asking you to unmute yourselves, and you can ask us questions regarding what are the. I'll be also asking you the questions that what are the other causes, what are the other differential diagnosis that is coming in your mind, and any other questions if anything is coming in your mind. So please unmute yourself and join the discussion.
Sir, can you please repeat the part of the differentiating between pain more than weakness and weakness more than pain?
So pain more than weakness will be your tendinopathies, bursitis, partial thickness tear. If weakness is more than pain, then possibility of the larger diameter nerves, means motor nerves, any of the pathology involving the motor nerves. It can be a space occupying lesion, it can be something impinging the foramen or radiculopathy, or it can be a complete tear. Complete tear, normally the pain becomes less, the weakness becomes more profound than the pain. Okay?
Oh, okay, sir. Thank you.
Sir, may I add one thing, sir, here?
Yes, yes, of course.
Sir, when usually this is for the only for the class. Usually, when these kind of patient comes, we can also inject a small amount of local, about 5 ml of local anesthetic in the subarachnoid and subacromial bursa, and
Yes, if we
repeat
are
the
having
test.
some doubts, that is very
Okay,
important.
and
If you are having
sometimes
some
it can.
doubts, if you are having some doubts, we can inject the local anesthetic and we see what is happening. Particularly, as I told you, the pain, if it is prohibiting or inhibiting to do any movement restriction, then you can give the local anesthetic in the part supplying the nerve, and you can again perform the same test, and you can see whether the range of movement is increasing or decreasing or what is happening. Series, there are some questions in the chat box. Empty can test need to be done on the both side or the affected side. So if if there is if you are comparing, if one side is affected and other side is normal, then comparison gave you the very good clear idea. But suppose this can happen that the both the side is affected, equally affected. Sometimes you might be getting this kind of patients as well. So individually each joint assessment is important. But if it is unilateral, you'll be having a better view comparing to the other side. But each individual empty can test is very simple. Just put the thumb down and ask the patient to raise, and you see what empty can test and drop arm test are similar. Drop arm test is basically to see the power, and empty can test is also by the power. So both are almost similar. Drop arm test is you hold it and see whether there is dropping, and drop arm test is for the complete tear or severe weakness of the arm. But if there is a partial thickness tear, drop arm test might not be positive, but empty can test might be positive. Okay, series.
Sir, good evening, sir. Sir,
So one,
lignocaine injection into subdeltoid acromial bursa.
yeah. So after injecting, if the range of motion improves, then it is usually there is a pain is more than the neurological part is less, but the tear is there is no tear, but tendinopathy might be there. But even after giving injection, local injection, if the range of motion is not improving, then there can be a muscle tear or other neurological deficit. We have to think about that rather than the tendinopathy. So if there is tendinopathy, range of motion will improve after giving local anesthesia in the bursa. But if there is tear or neurological deficit, then the range of motion will not increase even after giving injection in the subacromial subdeltoid bursa.
Thank you, sir.
Okay, series. Some other questions are there in the chat box. So that is what are the other neurological signs or any sensory deficits in this patient? Was it there?
So there was no other the sensory in the all the dermatomes was normal, especially C5, C6, C7 and T1. The sensory both hand had a equal sensation and reflexes were also normal. So here only the motor deficit was only physical finding that I could achieve, but other like sensory in various dermatome that supplies to the hand as well as the reflexes were all normal in this patient.
In this situation, normally, if it is something the nerve which is supplying this rotator cuff, it is not the same nerve which is supplying all the rotator cuffs. So it is a very complex scenario that only why the rotator cuff tendons are weak, the rotator cuff muscles are weak without any other neurological signs. This is very surprising to me. Still it can happen, but what was my suggestion that why have you not done also an MRI test of the shoulder joint? Was it done, or was it been advised by after you have referred this patient to the others?
No, sir. Actually, she came for the management of adhesive capsulitis, thinking that it was adhesive capsulitis, and she also received one injection in the shoulder joint, yeah, the steroid injection in the shoulder joint. But even after the shoulder joint injection, her range of motion did not improve. So I think the examiner who examined the patient only checked the active range of motion. They didn't check the passive range of motion. So here, since the active range of motion was decreased, but passive range of motion was very normal. And at the same time, I told her that this is not due to the frozen shoulder. It is any other pathology. There can be tear in the muscle, or I usually thought it was only supraspinatus tear. But after while doing examination, all the muscle weakness was evident in patient. And I thought it was a red flag because the motor deficit was not
motor deficit.
clinically explainable.
Yes, it should be motor deficit is always a red flag. Particularly if what I have seen in the video also, we have seen that the drop-on test was positive. Power, even patient cannot hold it against gravity. If the patient is unable to hold it against gravity, means it is your grade 0, means it is hold it against the gravity. That means the power of the muscle is basically grade 2. So in this situation, it is a red flag and further investigations to be done. So I was just interested to know what was the further investigation finding. But anyway, you was not in touch with the patient. So what we can discuss in the further regarding any other questions or any other causes of the shoulder pain, and we can plan the management of the different causes of the shoulder pain. So if any questions are there, you can ask me, and then quickly we will be discussing about the management of the few common causes of shoulder pain, like your adhesive capsulitis, your osteoarthritis of the shoulder joint, then your subdeltoid, subacromial, and subcoracoid bursitis, rotator cuff tendinopathies, bicipital tendinopathies, AC joint osteoarthritis. So these 6-7 causes are the common causes, and we will be discussing about the management plan of all those things. Somebody was asking some questions. You can go ahead with your question. Then we'll be discussing all these management plans.
Good evening, sir.
Yes,
sir,
yes.
I have, sir, 2 questions. Number 1, sir, empty can test, if it can, I'm not clear in empty can test, sir, if it can be explained, sir. And sir, my second question is, sir said the case he discussed, he said there was motor deficit, sir. And she's also a case of PIVD, old case of PIVD, sir. She was operated for that in 2016, sir. Sir, without sensory deficit, only motor deficit, is it possible, sir?
Yes, it is possible. It is possible, though it is rare. So most common reason, this is one of the things, not in the cervical area. You always remember it anywhere in the spine. If the patient is presenting without sensory deficits, without pain, predominantly motor deficits. So normally it happens in some space occupying lesion. It can be a slowly growing tumor, it can be some fibrous tissues which causes predominantly motor loss without having much of sensory loss. So this is one of the things what is possible. So in this patient, further investigations to be done, in particular this patient, and series is not aware of exactly what happened after the further investigations. So it is difficult to discuss what was the final diagnosis in this case. And what you have to remember again, when there is profound motor weakness, this patient definitely to be managed in association with the other specialists together. This is not a case where a pain physician should be treated when only the motor weakness and no other pain or other sensory deficits, no other cases. So these cases to be dealt with the spine surgeon or neurologist, or then these patients are not a pain physician's case. So coming to the other question,
Sir?
empty can test. Just let me explain the empty can test to the Bindu. So empty can test is like this. Can you see my? So empty can means you are having a can in your hand and you are emptying. So how will you do? Like this. Understood? You are emptying
Yes,
this.
sir. Yes, sir.
Means your thumb will be rotated downwards. And in this position, if you are doing the abduction, it is mostly the supraspinatus. So in that way, you do the abduction and you just see what is happening. Okay. So supraspinatus strength can be assessed with this empty can test.
Thank you, sir.
Okay. Somebody was asking some question.
Sir, I just wanted to
Yes.
know, was the patient having only the rotator cuff weakness and no other upper limb hand muscles like biceps, triceps, elbow joint, hand? Because the patient
That
had
was also my question to series. That okay, only other the weakness of no other muscles, only these three rotator cuff. That was also very surprising to me, and that was why I was interested to know what was the final diagnosis made by the neurologists.
Other tests, I examined the speed test and Yergerson test. Both speed test was normal. She could easily flex the elbow, but it was the power was 4/5. It was not 2/5, like the rotator cuff.
Means
There
mild weakness
was
was there, not that profound
slight
weakness.
weakness. Yes, not that profound weakness. And other muscle weakness test was all other test was all positive, sir. Negative, sir. Only the rotator cuff problem was there.
That was very surprising, no? Because rotator cuff is not supplied by only
But-
one root. There are several roots are involved. So only the rotator cuff weakness without weakness of the other muscles, that is very surprising. That's why I was interested to know the result, what happened to this particular patient, what was the investigation results of this particular test.
But sir, it has already been 1.5 months, sir. But I have a contact number of the patient. I usually, if you see
Okay. So you
I can-
just follow
I can
up
call
and
them
in
and
the
again-
next class, in our
Yeah,
next
yes.
class, we'll be discussing about what happened to this patient.
yes, sir, definitely, sir. What are the investigation approached and
Yes.
uh,
So other investigations, what can be done in these patients is the EMG and NCB studies and the shoulder joint ultrasound also I'll be just thinking, and of course the MRI of the cervical spine also has been done. So MRI of the shoulder joint could have been also done. So you just inquire and you just see what are the other positive things, what was the diagnosis in this particular patient.
I did the ultrasound examination and it was normal, sir. Ultrasound examination.
I understood. Already you told me that. Okay, so let us go to the next part of this. So we'll be discussing briefly about the treatment protocols of the different kinds of shoulder pathology. So coming back to let us start discussions with the most common part. The most common shoulder joint pain, or amongst the few most common causes, is one of them is the adhesive capsulitis or the frozen shoulder. So frozen shoulder, one of the very established treatment by the orthopedicians was the manipulation under general anesthesia. So under general anesthesia, patient hand was rotated, mobilized, and the adhesions are broken down. Nowadays, another option for doing this, breaking the adhesions, is by distension of the joint capsule, glenohumeral joint capsule, and either by anterior approach or by the posterior approach. Anterior approach means through the rotator cuff interval. Posterior approach means posterior, the glenohumeral joint. We can distend the joint by injecting around 25 to 30 cc of normal saline, or it can be steroid injection, or it can be mixed with the PRP. Main aim is to distend the joint, and you can break the adhesions, and you can start the exercise program. So this is one of the evidenced treatment. Other treatment which is also having some results are the intraarticular steroid injection. And recently, some papers are coming in favor of the PRP injection also without distension of the joint. Distension of the joint is little painful. So before distancing the joint, either you inject local anesthetic inside the joint and then you distend, or you can block the nerves, particularly the suprascapular nerve block can be done before distensions. So they are the treatment protocols for the your adhesive capsulitis. Then comes your osteoarthritis of the shoulder. Osteoarthritis of the shoulder, nowadays the most common treatment what we do is your intraarticular PRP injection, platelet plasma injections, and in a very severe advanced osteoarthritis, we can do the ablation of the nerves, particularly the three joint nerve ablation, suprascapular, the axillary, and the lateral pectoral articular branches without damaging the motor nerves. So this is the treatment options for the glenohumeral joint osteoarthritis. Then come rotator cuff tendinopathies or tear. Rotator cuff tendinopathies and tear, you have to identify with your MRI findings and ultrasound findings, and you can inject the PRP injection within the substance of the tear, area of the tear, or in the where there is tendinosis, and you can inject there. And if it is a complete tear, then we should be referring this patient for the surgical repair. We should refer this patient to the orthopedic surgeon. Then comes the AC joint osteoarthritis. AC joint osteoarthritis is again common. We can give the intraarticular PRP injection there. And then comes your bicipital tendinopathies, where you can give the PRP injections. For the bursitis, best form of treatment is steroid injection. Subdeltoid subacromial bursitis is one of the very common cause of the shoulder pain. Under the ultrasound guidance, we can give the steroid injection there. Subcoracoid bursa is another. So there also you can inject the local anesthetic and steroid. Bicipital bursa around the bicipital, basically that is a continuation of the glenohumeral joint. There also you can go for the injection of the steroid. So this is just outline about what are the different management options for the different shoulder pain conditions. So now if you are having any questions about this, you can ask us. Hello?
Sir, 5%, good evening, sir. Sir, 5% dextrose also in hydrodissection of the joint, sir?
Hydrodilatation of the joint, not hydrodissection, it is called hydrodilatation. So basically you need some volume. That volume can be normal saline, that volume can be 5% dextrose also, but not the hypertonic dextrose. This much of volume of hypertonic dextrose should not be given. We must be giving some physiological solution, which will be distending and which will be quickly absorbing. So if you are giving the hypertonic dextrose, that will not be absorbed quickly. So 5% dextrose is also an option. But if you are asking about the literature support is more in favor of the normal saline rather than 5% dextrose.
Thank you, sir.
Any other questions? As Dr. Series already told, shoulder pain is the third most common. Very frequently, you will be encountering this kind of patient. Yes. Hello.
Frozen shoulder, sir.
Hello. Dr. Jaya Muru.
Jaya Murugavel, sir.
Yes, tell how
to differentiate between bioccipital tendinopathy and frozen shoulder, sir. They both have pain anteriorly, sir.
Series, will you answer? Yes.
Yes, sir. So normally in case of frozen shoulder, pain is more not only anteriorly, pain is normally global, and more pain is in the lateral aspect of the shoulder. Second is in bicipital tendinitis, the active and passive range of motion will be normal. But in frozen shoulder, main is the active range of motion along with active as passive range of motion will be decreased. So this is one of the clue in
bicipital. This is the most important, I should say, that both active and passive range of movement will be restricted in the frozen shoulder.
Okay, sir.
And apart from that, some special tests are there. Okay, like speed test and Apple's crash test for the frozen shoulder, and the speed test for the bicipital tendinopathies. This test can also be done.
Okay.
The range of motion. So most important thing is range of motion. If both an active and passive is the most important thing is range of motion. Okay, so if both active and passive is restricted, it is either glenohumeral osteoarthritis or frozen shoulder. But in bicipital tendinitis, there is never decrease in range of motion, both active and passive. And in bicipital tendinitis, basically pain is in the anterior aspect of the shoulder joint, and speed test and Jagerson test are the will be positive.
Okay.
Okay,
Thank you.
few other questions in the chat box. One is, can we mix steroid with the dextrose?
So in
So
frozen shoulder, if the patient comes to OPD, we directly go for the local infiltration or we'll start with some analgesics and also.
No. Always go for the conservative management first. I would usually go for physiotherapy, as most of the cases will be improved with physiotherapy if the patient physiotherapy and some long-term and short-term NSAID. So we can give her duloxetine for a long-term pain management, and simultaneously we can send her to physiotherapy for improving the range of motion. If physiotherapy and oral medicine is not improving, then only we go for intervention. So one of the most common intervention is to block the suprascapular nerve as at splenoglenoid notch, and then go for hydrodilation of the shoulder joint, either from anterior approach or posterior approach. But always remember to start with conservative management initially. If it is not relieving, then only we go for the intervention. And in majority of case, in 60-70% of case, physiotherapy along with oral duloxetine and occasional NSAID will basically help the patient. If this is not helping, then only go for intervention.
So can we add magnesium also? I have read somewhere the magnesium tablet.
Sorry, what about
I always tell these things. Today also in the morning class, I was telling that you have read somewhere, don't incorporate that in the treatment part. So always go ahead what is evidenced. Evidence means whether it is coming in the guidelines, whether it is there in some of the protocols, then only you do it. Otherwise, only one or two single papers, or even if it is RCTs, should not be incorporated in your practice.
Okay, sir.
Okay, so coming to some of the questions in the chat box, one of the question is again mixing steroid with the dextrose. Again, it is not evidenced. Only steroid is there. Steroid with the normal saline is there. Dextrose, only few papers, not much as your the normal saline. And dextrose plus steroid, at least, theoretically, there should not be any problem. But again, we should do the things which has been there in the guideline or the protocols or some meta-analysis at least. So dextrose and steroid papers are not that, which is not that popular. So I'll not be telling you, if you wish to mix steroid, mix with the normal saline and local anesthetic, not with dextrose. Then is repeat the articular. Okay, so shoulder joint, the major nerve supply anteriorly by the lateral pectoral nerve, articular branch of the lateral pectoral nerve. And how to catch this articular branch of the lateral pectoral nerve? Over the coracoid process, you put your RF needle or cryo needle, and you can ablate the articular branches of the lateral pectoral nerve. This is for the mostly the anterior shoulder pain. For the superior and the lateral shoulder pain, mostly the lateral shoulder pain, it is the axillary nerve. So how to catch the axillary nerve? At the junction of the shoulder and the head and the neck, the axillary nerves comes to the quadrangular space along with the posterior, the humeral circumflex artery. And then after going to the lateral part of the humerus, it gives us the muscular branch to the deltoid muscles, and then further it goes up to supply the shoulder joint capsule. So to target the superior lateral part of the shoulder joint, you should be targeting the axillary nerve articular branches. And that can be targeted at the junction of the head and neck of the humerus. And the most important, the most wider area supplied by the nerve articular branch is the suprascapular articular branch. And already Series has mentioned it, that should be targeted at the spinoglenoid notch, where only the articular branches are there. The nerve to supraspinatus and infraspinatus can be spared. Earlier, we used to do the block at the level of the suprascapular notch. Nowadays, those are obsolete because that can cause the weakness of the supraspinatus, infraspinatus. So the blockage at the suprascapular notch is nowadays not done. The same nerve can be targeted more distally, where only articular branches is there, that is in the spinoglenoid notch.
Sir, can we target suprascapular nerve with the anterior approach, that is the subomohyoid approach?
Those are not popular. And again, as I was telling you, some researches are there, but not popular. So which is established, which is recommended, is to go ahead where the nerve is curving and coming in the suprascapular, the spinoglenoid notch. That is the area at the slope of the glenoid. That is the area where you should be targeting. And there safely you can do 2-3 lesions without damaging any other fibers. Anterior approach, the most important thing is the branches from the brachial plexus. So anterior approach, any of these capsular branches is always dangerous because of those fibers are very close. The brachial plexus fibers are very close. Posteriorly, all those nerves are not there. So posteriorly, the standard procedures for the suprascapular nerve is at the spinoglenoid notch.
Yeah, thank you.
Sorry, sir. Sir, for the frozen shoulder, how long do you allow the conservative treatment before the intervention?
Okay, first of all, we should be knowing that the frozen shoulder is a self-limiting condition. Suppose you are not treating a frozen shoulder, what will happen in the long run? Will the shoulder will be, the patient will be incapacitated, shoulder movement will be permanently restricted? Answer is no. So normally the frozen shoulder is self-limiting, and after 3 to 4 months, gradually the symptoms relieves. First pain relieves, the stiffness continues, and later on stiffness also gradually go. So that is the reason what Dr. Series told, that we need not be aggressive in this treatment. So if the patient is having the continuous pain, if the patient is unable to sleep properly, if the range of movement is so much incapacitating, these are the conditions where you should be thinking of the interventions. So coming back to your question, that how long should we continue the treatment of conservative OAs, depend on these factors. If the patient's lifestyle is the jeopardized, quality of the life is jeopardized, if the patient is having the sleepless nights, we should be going for the interventions. Otherwise, we should try for the conservative management, hoping that in the long run, the patient will be having the spontaneous recovery of the adhesive capsulitis.
Okay, thank you, sir. So how about for the hydrodilatation? Do we do it under ultrasound guidance or?
Obviously, it cannot be done blindly. As already Series mentioned, I also mentioned that to inject anything into the glenohumeral joint, we are having two approaches. One is through the rotator cuff interval anteriorly, either side of the biceps tendon, or by the posterior approach. And our aim is to distend the joint. How to know that, okay, you have distended properly? You'll be seeing that your joint capsule has been elevated, both by when you are scanning it posteriorly or when you are scanning anteriorly, you'll be seeing that the fluid will start appearing around the bicipital tendon. So when you see that it has been distended nicely, and normally how much, it is difficult to assess by looking at the distension, but total volume should be approximately 25 to 30 cc. But again, in some of my patients, I've seen the patient is having the pain because of the distension. So you may stop it. But what is the common findings? That initially pain is there, but once the distension, the breakage of the adhesions, the patient suddenly the pain will be reduced, and suddenly the range of movement will be improving very much. So the range of movement improvement is normally immediate.
Okay, thank you,
Good
sir.
evening, sir.
Yes, yes.
Good evening, sir. I did one injection through the rotator cuff interval. I've realized that around 10 mils of saline, that will be adequate to relieve the pain, or do we need to give more as compared to posterior approach?
You know, even if you are giving whole 25 cc from the anterior approach, that is also okay. And you can check by the holding the probe in the posteriorly to see how much your joint capsule is elevated. So as I told you, when to stop. If you are giving 25-30 cc, you can stop. Or if you are seeing the patient is having too much of pain, then also you should stop. 10 cc is normally not adequate to break the adhesions. Maybe partial adhesive lysis will be there. In my practice, I stop at 10 ml or 15 ml if the patient is having too much of pain. Otherwise, I go little, inject the little larger volume and to break the adhesions.
Thank you, sir.
Okay. So either you can go for both anterior, posterior, or you can go only with the anterior or only with the posterior. Any of the approach can be done.
So, post hydrodilatation, joint pain will be there for few days in the patient, sir?
Yes, yes, pain, but not much. Range of movement will be restricted, it will be improved, and the pain will be initially the maximum pain when you are distending it. After that, pain will be reduced. And after a few days, after 3-4 days, when the pain will be reduced, the very important part is active mobilization of the joint. With the help of the physiotherapist, you should do the rehabilitation program. That is very important.
Sir, after hydrodilatation or a PRP injection, hot fermentation or cold fermentation, anything is contraindicated, or we can
No,
keep
not
it?
contraindicated. You can go ahead with that. Either of that, whatever is giving comfort. Normally, after breaking the adhesions, cold is better. But if some patients cannot tolerate the cold nicely, so you can give the hot fermentation as well. Most important part, what should be done is the movement. Active movement is most important part. Otherwise, there are again the adhesions. But the way of pain relief, it is your choice. You can do any of the things.
Sir, immediately after post PRP, patient will complain of severe pain sometimes.
Yes.
So
yes.
mobilization means it will be like they will
Mobilization
say,
means a patient should be doing the active use of his hand, and the active exercise should be started 3-4 days later when the initial pain has reduced.
Okay, sir, thank you.
But many patients ask, shall I use it? Shall I give the rest to the hand? Shall I use a sling there? All those things are not needed. Patient should be using hand actively, and the exercise program should be started as soon as the pain has reduced. Pain of the procedure is reduced. Normally, it takes few days.
Hypothetical situation, usually in adhesive capsulitis, they have multiple things like osteoarthritis might be involved because of the age also. And you will see partial tears in all the rotator cuff muscles. And you would have tried physiotherapy
This is
and
not hypothetical. This is not hypothetical, Dr. Sneha. This is very common. You know,
yes, sir. I have seen cases like that.
Only adhesive capsulitis without rotator cuff tendinopathy or tear or AC joint, without involvement of the AC joint or without some of the effusion, so this is extremely rare. So
yes,
only adhesive capsulitis is a hypothetical situation. But what you are telling, this is a reality.
it is
yes,
a norm.
go ahead.
Yes, sir.
Go
I've
ahead with the
seen
question.
case like so. In these cases, should we try injecting in all places or like after doing the conservative management?
What is important? This is not true for not only true for the shoulder. I always tell these things to everywhere, including spine or everywhere, that on our imaging, you might be finding pathologies at multiple areas, but not all are painful. So if you find, suppose you are doing an empty can test and you are doing it is normal. There is no pain on the abduction, active or passive, and the test for the supraspinatus is normal. But on the ultrasound, you are finding that the patient is having the tendinopathy or partial tear. Question is, should we go ahead with the treatment of that particular tendinopathy or tear? Answer is big no. So this is true for many other situations. That means when you are seeing the multiple pathologies, you have to understand what are the different pain generators. And if you are still having the questions or doubts about what are the pain generators, what Dr. Series told, that you should be giving local anesthetic to your suspected pain generator to understand whether that is really source of pain or not. And then you plan your management. So it is not that in the ultrasound findings or MRI findings, you find multiple pathologies and you are all injecting all of them. No, it's not needed and not recommended also. You have to do your clinical test also. And in confusion, you can give the local anesthetic. So finally, you can make a list. This is my target, and then accordingly you do. And sometimes there is a confusion. Real confusion is somewhere else. I am telling you. Suppose somebody is having the rotator cuff tendinopathy. I'm just giving a hypothetical or maybe a common, this kind of patients you very frequently see. Somebody is having a partial tear of the supraspinatus. Somebody is having the bursitis of the SASD, and somebody is having the frozen shoulder. These three together. It's not uncommon. Many times you see these things. So now the best treatment for the bursitis is your steroid. Best treatment for the supraspinatus tear is your PRP. Best treatment for the your adhesive capsulitis is hydrodialysis. So what should you do? You cannot combine this steroid plus your PRP. So in this situation, you have to understand one important thing, that the patient, the most important part, bursitis is always associated with the pain. So here the pain reduction is your primary. So here in this situation, if this patient is coming to me, what shall I do first? I'll be giving the SASD bursa steroid injection. I'll be reducing the pain and I'll be re-evaluating the patient after 1 month. If by that time, if you see that the tear is still symptomatic or adhesive capsulitis is still symptomatic, so next time I'll go for your hydrodialysis with the PRP injection. So you have to rationally think targets. You have to assess with the clinical scenarios, clinical assessment, and then you have to plan the management in a most rational ways. Have I been able to answer your question?
Sir,
Yes, sir. So there
Yes,
will
yes.
be usually multiple sittings of the patient. We need to convince them for that. That
Yes,
is what.
suppose if you are getting this kind of condition that there is a bursitis and partial tear, you cannot treat both the conditions together. You cannot. So you have to tell the patient.
Yes. Okay, sir. Thank you, sir.
Sir, excuse me, sir.
Yes.
In case of bursitis, is there any amount limitation that fluid means before injecting steroid, we have to aspirate the fluid then inject, or
Most of the
whatever
times
the
you
condition?
cannot, this fluid is not this much that you can aspirate. So aspiration of the fluid, it's not like the knee joint where you can aspirate it. So aspiration in the most of the situation is not possible and not needed as well. So you can go ahead with the directly with these things. I can remember in my practice, I have been able to aspirate the fluid from the bursa only in 2 situations. One of them was subcoracoid bursitis, is a very big bursa where I have aspirated fluid, and another situations from the glenohumeral joint, but these are extremely rare. In my several thousand cases of the shoulder pain or shoulder pathologies, only in these 2 cases I can remember I could aspirate it. Most of the times you cannot aspirate and it is not needed also.
Sir, I remember
Sir, sir, sorry, one more thing. Is the chronic bursitis, is there any bursal wall thickening or some will you consider before giving steroid?
Yes, bursitis, whether it is associated with the bursal wall thickening or not, steroid is the choice.
Okay, sir. Okay, thank you, sir.
Okay.
Excuse me, sir.
Yes,
Sir,
yes.
what about ganglion, huge ganglion, sir, around the shoulder, sir? Over the subscapularis muscle, covering the acromioclavicular joint, sir. Can we aspirate and inject steroids?
You can aspirate the ganglion fluid and you can inject steroid, but most of the times there is recurrence, so surgical excisions might be needed. So there's 2 types of treatment. If it is, first of all, if the ganglion is small, it is asymptomatic, leave it alone. Don't do it. Don't disturb it. If it is symptomatic, then your option is you can aspirate and give steroid. If there is recurrence, surgical excisions. These are the 3 types of management plan for this ganglion cyst.
Sir,
Thank
can
you,
I
sir.
add one more thing, sir? Here.
Yes. Serious, you can participate in discussions.
Normally ganglions are not painful in shoulder joint. Sometimes the ganglion can be large, and it can extend to the suprascapular fossa and can cause suprascapular neuropathy, or it can come down and compress the suprascapular nerve, axillary nerve or suprascapular nerve, and cause neuropathic pain. And in these conditions only, we basically ultrasound guided, we aspirate and put steroid. Normally ganglion itself is not painful, or it doesn't do anything unless it impinges the nerve. Then it can cause neuropathic pain, mainly the axillary nerve or suprascapular nerve, either in the splenoglenoid notch or inferiorly towards the axilla. In these conditions, we aspirate. Otherwise, ganglion itself is not painful, and we don't do anything. Asymptomatic ganglion, whether it's big or small.
Thank you, sir.
Okay, some question in the chat box. One is your how to assess the examination of the hemiplegic frozen shoulder management. Okay, in the hemiplegia, there might be, you can understand that there might be some weakness of the motor fibers or other things, but otherwise the management plan is same. Frozen shoulder diagnosis is very easy. You have to do all the movements and you see whether it is restricted. Both active and passive will be restricted. And the most important differential diagnosis of the frozen shoulder is your osteoarthritis of the shoulder joint, which can be easily understood by a simple X-ray or even the ultrasound. You can see that the surface of the your humeral head will be irregular and the cartilage will be, hyaline cartilage will be very much thinned. So this is the way what we can do it. So if you are having the range of movement is grossly restricted, then you should be go ahead with the further examination with the image to see whether there is an osteoarthritis or not. If osteoarthritis is ruled out, it is always frozen shoulder. And even if you don't need any MRI or other things. Another question was, is there any backflow through the needle? Answer is, if you are using the larger gauge needle, then there might be backflow. But if you are using the 22 or 23 gauge needle, you may not be having the appreciable backflow. Okay.
Sir, I wanted to ask a question.
Yes, yes.
Sir, if a patient comes to us with some complaint of shoulder pain, and if he already gets an MRI with him, sir, are we supposed to go ahead with ultrasound scanning also, or should we rely on that MRI report, sir?
The thing is, when you are already having the MRI, what is lacking in the MRI is the dynamic examinations. As I told you, some of the impingement and dynamic examinations, you cannot do it. I'm giving you a very important the two important clues I am giving you. Why additional ultrasound scanning will be important. One scenario is, suppose patient is having the full thickness tear. So full thickness tear, it's not always going to give the surgical interventions. What is the difference between the full thickness tear and the complete tear? Complete tear means the both end has been detected. If the MRI findings is there that okay, both end is detected, definitely surgery. But sometimes the MRI report comes with the full thickness tear, but the additional ultrasound scan, you can understand how much retraction is there. If you can read the MRI plates very nicely, that's fine. But otherwise, ultrasound scan can give you some ideas about how much the ends are retracted. Second important part is your impingement. Means with the dynamic examinations, you can understand how the say for example, the coracoid impingement, how the lesser tubercle is going under the coracoid or not. So this kind of dynamic testing is not possible with the MRI. So you can additionally, MRI have some value. I'm not telling you that the MRI and ultrasound is alternative to the MRI and you must be doing it. But some additional advantage with the MRI ultrasound examination is there. But that is not important. Important is MRI might, if it is a pathology, you have to correlate clinically that whether that particular pathology is producing pain or other symptoms or not. If it is not, then you need not treat that conditions. So this is true both for ultrasound as well as for the MRI. And I give this example, it still is not published. But again, I always give this example that we had a test in the healthy individuals who never ever had any shoulder pain. And we did the ultrasound scanning of the supraspinatus. And you know what was the findings? Findings was 1/3 of them was having the tendinopathy, 15% of them was having the partial tear, and 2% of them was having the complete tear, who never ever had any shoulder pain. So that means the ultrasound scanning or MRI scanning can give you some pathologies, But if the patient is asymptomatic, range of movement is fine, then we need not treat that condition. This is true not for the shoulder. This is true for the spine and many other joints. So, and it's, the radiologist always write one line at the bottom of the report. You know what is that? Please correlate clinically. So this is so important.
Clinically, yes, sir.
So this is so important. So correlation with the MRI findings or ultrasound findings with your clinical findings is so important to plan a management.
Sir, I always remember till now also, you always tell that do not treat MRI or X-ray, treat the clinical condition of the patient. So whenever
Right.
there is MRI, there can be multiple pathology, but you have to make sure with history and physical examination and try to find out what is the main pain generator, whether it is correlating with the MRI or not, then only go for treatment plan. So always remember, do not treat it X-ray or MRI, treat the patient. Treat the symptom of the patient.
Yes.
Always go for the clinical examination, confirm it with ultrasound and in MRI, and then only plan for your management.
Thank you, sir. Thank you, sir.
That is one of the golden thing that always sorry used to tell us when we were in class in student.
Thank you, sir.
Okay. Any more questions? Next class will be by Dr. Milton. Milton, are you there?
So there is one question.
Hi, sir. One more question, sir.
Okay, one more question. What is that?
Sir, if the bursitis it comes back within 3 months of steroid injection, what to do, sir? If he complains of pain and if
You
he
have to repeat
scans,
it again. The thing is, earlier use of the steroid injection and nowadays giving of steroid injection is different. Why? Because earlier we used to give a large volume with a larger dose of the steroid. Earlier recommendation of the shoulder joint or any other large joint was up to 80 milligram of the shoulder steroid. But nowadays we don't give more than 20 milligram because we are giving right at the target. But what is more important in these conditions, to rule out any underlying inflammatory disease conditions. Like this kind of recurrent bursitis, which is there and again coming back, you have to rule out the inflammatory arthropathies like spondyloarthritis, like rheumatoid arthritis, or any other seronegative arthritis. So this condition must be ruled out to understand whether what is the real, is there any real underlying pathology, systemic pathology, which is responsible for the recurrent bursitis. You have to treat that condition. Okay.
Okay. So the patient, he had only shoulder pain, no other joint pain or
I
inflammation.
understand. Monoarticular inflammatory arthritis is not uncommon. So you have to rule that. Rule out that.
So in
Thank you, sir. If at all we can give.
But what is important, suppose you have given a steroid injection. This is true not for the shoulder, again, not for the bursa. Always remember this condition. Suppose you have given a steroid and there is a recurrence. So how soon can you repeat it? This is a very important question. Many times, not just in the bursa, in any other conditions, this question might be coming, that how soon or how closer you can repeat the second injection in that same area. So in this, you have to remember some of the theories. That means how long the deposteroid is effective in our body, how long there is adrenocortical suppression in our body. So normally you have to remember that the total dose of the steroid to be less than 3 milligram per kg body weight in a year. This is the ceiling dose. You should be always keeping less than that. Number one. Number two is the duration of the steroid action is something between the 3 weeks. The action is most profound. After that, gradually the action reduces, and after 3-4 months, the action basically ceases off. So if you wish to repeat the steroid injection, don't try to repeat it within a month, because then cumulative effect of the adrenocortical suppression will be there. So if it is an emergency, then what you can do is you can use the soluble steroid, because soluble steroid injection don't have any ceiling dose. So if you need to, suppose you have given a steroid injection and after 2-3 weeks patient is having again the problem and you are forced to give some other steroid, so that time you repeat the soluble steroid, not the deposteroid. And after a month, if the condition is really important to reduce the patient's pain is very severe, conservative management is failed, then you can plan for another steroid injection only after a month. But again, conservative management, systemic things to be ruled out. Okay?
Okay, sir. Thank you, sir. Thank you.
Okay, so thank you very much. And I also enjoyed the discussions. And in all our subsequent classes of this clinical part, I want discussions. Please ask
Sir.
questions. So we'll be discussing the different angles, different aspects, different treatment plans, different differential diagnosis, and then only we'll be able to learn it nicely. Okay, Siris, you are going to tell something.
Sir, in discussion, we are basically lacking few, like in tendinopathy and tear. What will be the line of we basically discuss regarding osteoarthritis and frozen shoulder only, but like supraspinatus or rotator cuff tendinopathy and tear are also
Okay, you can
common.
add something. You can add something. Go ahead.
So the rotator cuff tear and tendinopathies are also very much common in clinical practice. Till now, we were just discussing frozen shoulder and osteoarthritis. But like, if there is a nowadays a prolotherapy is gaining its confidence every day. So if there is a tear or tendinopathy, then role of PRP and dextrose prolotherapy are also very much commonly given by the pain physician. So in case of partial tear in the ultrasound or in the MRI, we can easily treat this by minimally invasive PRP injection in the tendon, which has an excellent result. Or we can, if the patient is cannot afford PRP, or if there is some problem where PRP injection is contraindicated, then we can go for 12.5 or 15% dextrose as a prolotherapy for the management of the patient. So please do not forget that the PRP not only in the joint but in the muscle as well as in tendon. Nowadays, regenerative medicine is growing like very much nowadays. So we pain physicians are also injecting PRP and dextrose as a prolotherapy in case of muscle and tendon tear commonly. So I would just want to add that please do not forget PRP injection and dextrose injection as a prolotherapy in case of tendinopathies or tear, either it's a partial tear or sometimes in full thickness tear also, if the tear is not a complete tear.
So, sir, can you enlighten the prolozone, sir?
The Prolo basically we are using dextrose, which are hypertonic dextrose, such as 12.5 or 15% dextrose, to induce inflammation and then start the healing process. So basically, we are adding either PRP or dextrose, which will stimulate inflammation, and then it will again reinitiate the inflammation cascade and healing cascade, and the toward muscle or tendon will gradually go in the process of healing by itself. So that is the main theory behind the prolotherapy with dextrose.
So actually, prolozone was I was asking, sir, how much and like intraarticular prolozone.
Ozone, do we give ozone in the shoulder joint, sir? Normally,
Evidence is very poor. So as I was telling from the beginning, please state with the conditions which is evidenced, which is recommended. Prolozone therapy, some papers are there in the knee joint. Shoulder joint, I'm not aware. But again, in the knee joint also, the evidence is not that strong. And if you are really interested, you can design some studies. But still now, prolozone means ozone plus dextrose together in the joint. Some papers are there in knee joint, but shoulder joint not much.
And one more thing, sir, if patient is already having the steroid, like methylprednisolone or depot steroid, and on one side, and after that, if we have to give in another side, then we have to go for a soluble steroid, or we can go for the.
No, as I told you earlier, if the total dose is within the year is your less than 3 milligram per kg, then you can go ahead with the depot only.
Okay.
I told if this condition is applicable only when you are giving in a very quick succession in the same place. And second thing is the total dose limit exceeding 3 milligram per kg body weight. Okay.
No,
Otherwise, in the other joint, you can go ahead with the depot steroid only.
Okay, sir. Okay, thank you, sir.
Excuse me, sir. So can we know about bicipital tendinitis and bicipital tenosynovitis treatment, sir?
Yes, of course. So normally bicipital synovitis is also normally managed, usually managed conservatively with rest and non-steroidal anti-inflammatory drug. If it is not helping, then we can go for ultrasound guided steroid injection right at the target in the bicipital groove within the tendon seat and the tendon. But here you have to be careful that in shoulder joint, any other place you can inject very nicely, but here there is one artery in the lateral aspect of the groove. You have to prevent injury to that artery in the bicipital groove. But easily we can see the black color fluid around the bicipital tendon, and very precisely we can inject steroid and local anesthetic within the fluid within the tenosynovitis, which has a very good and excellent result.
So do we need to stop any drugs, NSAIDs or anything before giving intra-articular steroid like PRP?
In PRP, basically, it is said that non-steroidal anti-inflammatory drug, if the patient is taking, in some countries' guidelines, they stop it for 4 to 6 weeks and go for PRP injection. That can be done, but normally after PRP, we basically stop non-steroidal anti-inflammatory drug like ibuprofen, aceclofenac, these drugs for 4 to 6 weeks. And regarding antiplatelet agent, it depends upon, we basically see the risks and benefit. If the clopidogrel and aspirin can be stopped before injecting platelet, that is good. But if cannot be stopped, then we can go ahead with without stopping the clopidogrel or anti-aspirin. Normally we recommend stopping aspirin and clopidogrel like 3 to 7 days before injection. But sometimes if the patient,
but sometimes, the series, if it is very much necessity that the antiplatelet therapy must be continued, cannot be stopped for 7 days, then we can go ahead with the aspirin. Clopidogrel must be stopped, otherwise the result is poor. Continuing both also can be done in a very desperate situation if the cardiologist is not allowing at all that, okay, no, clopidogrel cannot be stopped also, then you can start give that also. But for the clopidogrel, the interventional the things as well as the PRP, the poor outcome is not that good. So the clopidogrel should be stopped. Aspirin may not be stopped. So this is the normally the standard one. But in extreme situation, you can continue with the both. And the best scenario is stopping both. But stopping both may not be possible in many cases.
So intra-articular steroid also we need to stop NSAIDs?
No, intra-articular steroid injections, the clopidogrel injection can be stopped because any of the interventions, for the spine, clopidogrel has to be stopped always. For the peripheral joint steroid injection, clopidogrel also preferably stopped. But suppose somebody is having the shoulder or knee or ankle, which is very superficial joint, and the patient is on clopidogrel, cardiologist is telling that, okay, clopidogrel cannot be stopped for 7 days, and then you can go ahead with some precaution that there is a possibility of the bleeding. Spine, you can never inject any procedures with clopidogrel. Peripheral joints, preferably clopidogrel should be stopped. But still in desperate situation, you can.
No, thank you.
So after
How long can we wait with conservative management for tendinopathy? So like, how long can we continue with the tendinopathy conservative management?
Normally, approximately your 3 months. Why? I told you the earlier as well that the patients might be having the spontaneous recovery. But again, if the patient is having too much of pain, disturbing sleep, quality of life, then you can intervene early. Already I told these things, that conservative management should be stopped if these things are there. Patient's quality of life is hampered, the daily life activity is hampered, night sleep is hampered. So these are the conditions where you can intervene early.
Sir, in frozen shoulder, after PRP, when can the active movements be started, sir?
What?
In frozen shoulder, you told after 3 to 4 days we can start the active movements. If we are giving PRP, when can we start?
I told another thing also, that I told that when the procedural pain has reduced, normally it is 3-4 days, but if in some days, some cases, if the pain is still 7 days or 10 days. So after the pain, initial injection pain is reduced, then only you should start it, not before that.
Okay, sir. Thank you, sir.
Okay, so we had adequate discussions, and let us close today's session. And if you are still having some questions, you are always free to ask us during the next, before we are starting with the next session. Next module will be there on the next your Thursday.
Sir, one more thing, sir.
Yes, yes, tell, we are there.
So like antiplatelet to start after injection, it is same like other interventions, or we can immediately
Same.
start?
No, no, same, it's same, it's same.
Okay, sir. Thank you, sir.
Okay, so thank you very much and good night.